welcome everybody to the CortiCare webinar series, which presents topics related to EEG neurodiagnostics, patient care management, research, and future applications. Today's event will last approximately 45 minutes. In a couple of hours, you'll receive an email with a link to an evaluation form for this webinar. We welcome your feedback, though this presentation was not approved for asset CECs because of timing issues with the application. You may still submit the completed online form, and a certificate of attendance will be sent to you in the next few days. On this webinar platform, you may enter in questions in the chat area, which, time permitting, will be raised and addressed at the end of the presentation. The National Association of Epilepsy Centers has produced standards for accreditation for epilepsy centers, in particular the guidelines for essential services, personnel, and facilities in specialized epilepsy centers in the United States. And it revised those guidelines in 2010. And they're the basis for the criteria that the NAEC uses to accredit level 3 and 4 epilepsy centers. They're now more than 10 years old and are due for revision, and the NAEC is forming a guideline panel to develop the next set of standards. Today's webinar reviews the standards a bit and the move to evidence-informed guidelines that will be under development over the next year. Presenting today is Dr. David Labiner. Dr. Labiner is professor and head of the Department of Neurology at the University of Arizona College of Medicine. He's a professor of Pharmacy Practice and Science at the University of Arizona College of Pharmacy. He received his MD from and completed his internship at the Medical College of Georgia and his residency at the Department of Neurology at Columbia University in New York and a fellowship at Duke University. He's former president of the National Association of Epilepsy Centers and is well positioned for today's presentation as he is directly involved with the process of revising the current standards. Welcome, Dr. Labiner. You can turn your camera on and I will back out.
Well, thank you so much, and I hope everybody can hear me. I am grateful for the opportunity to make this presentation. Appreciate CortiCare setting up the platform for doing so. So, like Jeff said, we're going to talk about the guidelines that have existed over the past 20 plus years and the evolution into the next set of guidelines. So I have no relevant financial disclosures to make regarding this presentation. So we'll start with the history of the National Association of Epilepsy Centers, commonly referred to as the NAEC. It was founded in 1987 by the late Bob Gumnett, who was the longtime director of the MINCEP program in Minneapolis, and others. He's shown here at his ranch in New Mexico on the left side of the slide. And the goal was a commitment to setting national agenda for quality epilepsy care. It was initially run out of Bob's office at MINCEP in Minneapolis. And Ellen Riker, who is still involved with the NAEC, was initially the Washington representative. And we'll circle back to Ellen a bit later. So thus far, there have been 3 iterations of the guidelines shown here. These are the references. The most recent one will be available through this webinar, so you can get a copy of that. It's also available on the NAEC website. So the first guidelines actually was an entire supplement. I say an entire supplement. It was a 12-page supplement of Epilepsia in 1990. And it was the recommended guidelines for diagnosis and treatment in specialized epilepsy centers. These guidelines are very different than the ones that are available today or the ones that are published today, the most recent iteration. But the goal is the same. It was to provide a framework for a systematic, well-organized approach to subspecialty epilepsy care. This was the first time the distinction between level 3 and 4 centers was made. But also, interestingly, there was a distinction between medical and surgical centers. Medical centers obviously providing pharmacologic care and surgical centers being able to both provide pharmacologic and surgical treatments. Keep in mind, back in 1990, there were no neuromodulatory treatments available at that time, so that was not part of the thinking. So flash forward to 2001, and Ted Walczak led a group that included myself in the rewriting of these guidelines and this too was published in Epilepsia. And we retained at that time the level 3 and 4 distinction, but level 3 had both the medical and surgical centers. So again, you could be a level 3 center and not do surgery, but provide high quality comprehensive medical care. But level 3 also could do simple, straightforward surgical procedures. In the level 4, the medical and surgical were combined. The thinking was that if you were providing this high level of service, you should really be able to do both and do both well. The level 4 distinction was really strongly based on the number of surgical cases that were being done at institutions, and that led to a very strong debate amongst those of us who were on the board of the NAEC at the time, whether this was really the best measure of whether a center could provide comprehensive care. And those of us who were on the side that this was not the best marker lost that debate, although you'll see when we came around to the most recent iteration, that number went away. So certification as a level 3 or 4 center had always been based on self-designation and then an attestation by the medical director. And the members of the board really questioned the veracity of the data that were collected regarding case numbers. And in fact, there were some, and it still happens, and although thankfully not as much anymore, but in some recent years, when asked how many cases were being monitored at a given place, we get answers of tens of thousands. And you start doing the arithmetic and saying, okay, and what we think happened is they were talking about days of monitoring as opposed to individual cases of monitoring. So one person would get monitored for a week. That doesn't count as 7 separate incidents of monitoring, but rather 1. So the data were suspect, the number of surgical cases were suspect, but nevertheless, that's what we had in 2001. Flash forward then to the most recent iteration that Jeff mentioned, the one that I was the lead author on that was published in 2010. And this was, again, an attempt to update the guidelines, but some real basic principles were changed in this. We consolidated medical and surgical centers and then developed common elements of level 3 and level 4 centers. And one of the main things that we emphasized was that there really needed to be an interdisciplinary care team approach. It couldn't just be one epilepsy person and a surgeon doing their bidding, but really a mechanism by which cases were discussed and reviewed, and the availability of necessary services to deal with comorbid conditions that we all know are present in patients with epilepsy. In this iteration, we once again described the electrodiagnostic facilities. That means an EMU. And while most everybody on this webinar probably would agree that an EMU is a necessary component of an epilepsy center, that was not always the case prior to this. And we had people who really didn't have a designated EMU, but had a couple of portable machines saying that they were providing the same type of service. We also emphasized the need for safety protocols and quality measures and the need for patient education. And as I mentioned, Jeff will make available the copy of the guidelines to anybody who wants it, but they are also available for non-members at the NAEC website. So in this 2010 version of the guidelines, these were thought to be areas of staff expertise that were needed at epilepsy centers. So we needed to have somebody who was qualified to evaluate patients for and to perform epilepsy surgery, people who could deal with vagus nerve stimulation and other neuromodulatory devices, people who were skilled in the use of anti-epileptic drugs. Clinical trials were some things that were also felt to be needed for pediatric centers, primarily availability of the ketogenic diet and all the necessary support that goes along with that, as well as genetic testing and evaluation and support from genetic counselors. We all know that there's a high percentage of psychiatric comorbidity in patients with particularly refractory epilepsy, and it was felt that that needed to be an available service at an epilepsy center, as well as management of women with epilepsy during pregnancy, including pregnancy counseling. So again, coordination between obstetrics and the epilepsy team. Obviously, neurophysiology expertise was necessary, management of non-epileptic psychogenic seizures, because that is a big percentage of what gets diagnosed at comprehensive epilepsy centers. Management of status epilepticus and seizures in hospitalized patients. Again, while patients, we don't intend to create situations where patients go into status epilepticus, it certainly is known to happen because very often we're reducing medications on patients in our epilepsy monitoring units, and that can trigger worsening of seizures and status epilepticus. It was felt that centers should have the ability to manage epilepsy in special populations. We already mentioned women, but also elderly, children, developmentally disabled, and then individuals with multiple medical problems. It seems intuitive that there should be high-level brain imaging available, but also the ability to deal with cognitive comorbidities that unfortunately so many of our patients have to deal with. And then finally, the ability to deal with the issue of alternative or complementary medicine. And living in Arizona, I can tell you that we have a huge percentage of patients that use alternative treatment strategies. And I'm not just talking about CBD and marijuana, but also other things. And one of the most important issues that we recognize is we have to ask about them. Patients don't always volunteer that information. So then third level epilepsy centers had to have long-term monitoring capabilities, the ability to do epilepsy surgery, and including vagus nerve stimulation, meaning that they could do routine lesional surgery. So somebody who was evaluated, had mesiotemporal sclerosis, they could provide that service, but they didn't necessarily need to be able to do invasive EEG monitoring. That was reserved for level 4 centers. They had to be able to perform various neuroimaging techniques, provide neuropsychological and psychological services, pharmacologic expertise, nursing support specific to epilepsy. So an epilepsy nurse specialist, and then educational programs for the nursing staff that would be tending to the individuals in our epilepsy units and in the hospital. Rehab. Now, this did not envision that every hospital that was a certified epilepsy center would have the ability to perform all levels of rehab, but there should be the ability to do physical and occupational speech therapy as an inpatient. The outpatient services could be through a relationship with a rehab facility in your community. Expertise in a variety of fields available for consultation, including neurosurgery, psych, medicine, peds, general surgery, and OBGYN. Neurologists with special expertise in epilepsy. This became much easier a few years after these guidelines were published because there's now a board certification in epilepsy that did not exist at the time of the publication of these guidelines. EEG technologists and related personnel, and we like to emphasize the need for certified technologists. That's certainly viewed as a benefit to an epilepsy center. Neurosurgeons with special expertise in epilepsy. There is no board certification for neurosurgeons in epilepsy, but there are fellowships available for those who train in neurosurgery to spend extra time specializing in epilepsy evaluation. We wanted to make sure that neuroradiologists and neuropsychologists were available, as well as psychosocial services, so for psychologists, social workers, and then for kids who are in the hospital, school services during the time they were in the hospital, although usually they're in for short enough a period of time that may not be necessary. Clinical pharmacy services and support, nurse specialists I already mentioned, rehab services I already mentioned, and then the interdisciplinary services are very important. And then IT support. Maybe the bane of my existence as a medical director of an epilepsy program is the issues surrounding IT. I suspect that's true in a lot of places as well. And then features that set aside level 4 centers included the ability to do functional cortical mapping with subdural electrodes either in the operating room or in the EMU, the ability to do evoked potentials with intracranial electrodes, electrocorticography writ large, the placement of intracranial electrodes. And while subdural strips and grids are a little technically easier to do, they still require special expertise, and then obviously depth electrodes that are associated with stereo EEG is something, yet another skill set that our surgeons have to have. Resection of epileptic tissue in the absence of a structural lesion was felt to be a level of surgical treatment above what a level 3 center would be expected to perform, and then experience by both the neurosurgeon and the epileptologist, and then relationships for the ability to do PET scanning or SPECT scanning to help support the focus localization done prior to surgical intervention. So many people ask, where did level 3 and level 4 come from? This was Bob Gumnett's original creation, but this is from the paper that I was the primary author on. And the idea is the same, that the primary care provider is the level 1 provider, that it could be a pediatrician or an internist or a family doc. And they're perfectly capable of doing an initial evaluation. They may choose not to and refer patients early on, but they're perfectly capable of doing an initial evaluation and then referring to a neurologist, a community-based neurologist, would be a level 2 evaluation. That's a general neurologist in a community-based setting, or referring somebody onto an epilepsy center if they're available. Then if the general neurologist, the community-based neurologist, wasn't having success in getting the seizures under control, they could refer in either to a level 3 or 4 center, depending on what was available to them. And the idea was that a primary care physician shouldn't try for more than 3 months to get seizures under control. If they weren't having success, they really needed to get them to a specialist. First, to question the veracity of the diagnosis. Does the patient really have epilepsy, or is it a mimic? And then to get the patient into the hands of a neurologist and then ultimately to an epileptologist if the seizures aren't being brought under control. And we can quibble over what the right timing of that is, but in this publication, we said a PCP shouldn't handle somebody for more than 3 months, and a general neurologist shouldn't handle somebody for more than a year without successfully controlling their seizures. So flash forward 2 years later, the Institute of Medicine published what many of us in the field felt was a really extraordinarily important document, and advised us to start looking at epilepsy as a public health issue, because there's a lot of people with epilepsy. In fact, the report quantified it as 1 in 26 people will deal with seizures in their lifetime. This report came out about the same time. The autism groups were talking about the fact that 1 in 80, now it's even more than that, but 1 in 80 people have autism, and yet our field, epilepsy, didn't get any press, whereas the autism groups, who were very vocal, and rightfully so, got a tremendous amount of press, yet epilepsy was arguably at least twice as common, perhaps 4 times more common. So in the Institute of Medicine report, recommendation number 6, one of the recommendations was, or the specific recommendation was, to establish accreditation of epilepsy centers and an epilepsy care network. And they suggested that a collaborative effort made between the NAEC and the American Epilepsy Society do this to develop an independent external review mechanism for accreditation, and that the validation by an external body would ensure excellence, consistency, clarity, and transparency in provision of epilepsy care. And those are their words. The boards of both the American Epilepsy Society and the NAEC determined that the NAEC would take the lead on that. And then we underwent a period of study where we started looking at a variety of models of accreditation. The Joint Commission obviously is perhaps the best known, but other professional organizations do similar types of things where it's on-site assessments. And when previously the NAEC explored this with its members, whether they would like a Joint Commission type accreditation, and there was a robustly negative response to that, because it is quite an intrusive evaluation, as all of you who work in hospitals know. The Joint Commission shows up, they may be there to look at one thing, but they're allowed to look at anything, and so you always have to be ready to deal with that. It's also very expensive to oversee, because you have to have a lot of on-site inspections, which requires a lot of people to do. And so we elected not to go down that path. we decided that we were going to set criteria and then require centers to provide proof via documentation that they had the personnel and services at their centers as they claimed. The NAEC would independently verify board certification status with the credentialing bodies. So if I say that I'm a board certified epileptologist, they're not going to just believe me. They're going to go to the ABPN and look up and verify, in fact, that I am certified both in neurology and epilepsy. So then it came about to what would the standards themselves be. And we used the 2010 guidelines because they were the most recent published guidelines that we had. And there were about 40 specific items that centers were expected to have. And using methodology that's used in setting standards typically for board exams and other types of things, and this is a validated process that's been used across board certification and other test type settings. The group, so we convened a group that was comprised of the then board as well as some former board members, and posed the question for these 40 individual items: in an accredited center, which of these essential features would they have, not should they have? Because everybody wants to say, oh, they should have everything. Well, but realistically, we said, okay, not everybody's going to have everything, but which things would everybody have? And we had surprising unanimity on the majority of items, probably 3/4 to 80% of the items. And then we went on a second round. So those were set aside and said those would be things that were required for the accreditation. Then we went through the second round and debated each of those items individually and reached consensus on those as well. And so we reached this consensus on the accreditation standards. So once these criteria were agreed upon, we circulated them to the various centers. I don't remember the exact number, but we have way more centers now than we did at the time. We sent them to the various centers and also to our sister organizations to comment. And we were really surprised. There was no pushback. It was universally, there was a positive response. It was about time we did this, that kind of response. The American Epilepsy Society formally endorsed them at their board level. And then over the next 2 years, we phased them in. And so they were in full force now 5 years ago. And the current process involves the filling out of an annual report. That's an online report documenting the services you provide, the personnel you have, as well as the numbers of cases of various things. And then to support if I say that I've done this, and I provide these services, I have to then provide reports that prove that I'm compliant, that I'm telling the truth. So if I say that I'm doing invasive monitoring or cortical mapping, I have to send in a report that's de-identified. All the personal health information is removed from the report and sent in to show that we actually provide that service. The NAEC board and the accreditation committee can revise the process regularly. And the whole notion behind the way we set this up is that over time we could increase the need to continuously improve quality of the services we provide at our centers. So what is NAEC doing now? They continue to develop standards of care and promote their adoption. There's education of the public, typo, sorry about that, and private insurers, policymakers, government officials about the complexities and need for patient access to specialized epilepsy centers. The big thing that one of the big things we're dealing with as an organization now is lots of private insurers are saying, well, these epilepsy monitoring can be considered an outpatient experience. And, we're trying to educate them that withdrawing medications puts patient at risk of severe seizures, status epilepticus, injury, and even death. And that's really not appropriate for an outpatient observation status in the hospital. So that's one of the big issues that we are dealing with. But the NAEC mission is to support epilepsy centers in delivering quality comprehensive care to people with epilepsy. And it was decided at the board level, and just full disclosure, I am no longer on the board of the NAEC, that it was time to update the published guidelines. They needed to be aligned with the center accreditation and undergo a more rigorous approach to developing them and involve a broader group of stakeholders. All the previous guideline iterations were written by a small group. And there was discussion, of course, about the contents of the different guidelines, but they were put together by a small group without a tremendous amount of broad-based input. So the board worked with a consultant group to start to look at how to undergo guideline revisions to inform the board about current standards for developing respected guidelines, both in the United States and internationally. And the board concluded that it needed to undertake an evidence-informed, consensus-based process using a Delphi approach. So part of the rationale is evidence is considered essential, a requirement of guideline development. And I want to emphasize that the prior guidelines all had evidence in them, but there's really not a tremendous amount of published data that says that what we do is the right way to do it or has good outcomes. So that's the point of trying to do it this way. Insurers and policymakers look to published literature to make coverage and payment decisions. And the revised guidelines with a literature evidence review would be needed to provide a published foundation for the accreditation program. So a request for proposals was put out to look for an organization that might be able to help the NAEC with this. And EBQ was the one that's was selected to work with the NAEC. This group has expertise and experience with, quote, trustworthy, consensus-based, evidence-informed guidelines. Their process is acceptable for guideline inclusion in recognized guideline repositories, and they have experience in developing guidelines using their methodology for other specialized centers. In fact, they are the organization that helped develop the World Hemophilia Foundation guidelines in 2020. So the scope of the project first would involve determining the makeup of the panel to evaluate the epilepsy center parameters. This is already done, and I'll come back to that in a minute. And then developing a conflict of interest policy and how to manage it for the members of the committee. Other things that need to be done are now formulating the key topics, parameters, and identifying important outcomes to be assessed, doing a systematic and comprehensive literature review to determine what evidence exists, managing a modified Delphi process to look for consensus on recommendations, drafting a document, and then identifying knowledge gaps and recommendations for future research. And like I said, the two things in red have already been, they're ongoing right now. So the NAEC will manage the guideline development process, but they wanted to do it with an oversight committee. So they wanted to carefully manage the literature review because the board rightfully felt that a consensus process would be needed because there's little good evidence in the literature to support some of the elements of epilepsy care that's provided at our centers. So they wanted to be sure that there was careful management of the literature search to cover a variety of these questions and include board members on the oversight group. So they asked former board member Christy Heck and myself to chair the Guidelines Oversight Committee. We will be responsible for the selection of members of the committee and monitoring conflicts of interest. The committee itself will have chairs that will oversee the day-to-day, month-to-month work and oversee the members and provide direction for the work. And we anticipate this process will be completed by the end of 2022 with a published document. So the guidelines committee composition, and this was done by a survey of the members of the board of what they felt would be important. Epileptologists, both adult and pediatric epilepsy surgeons, EEG technologists were the top 3 things that were felt to be necessary for this to go forward, but also epilepsy nurse specialists, social workers with epilepsy expertise, neuropsychologists, patients with epilepsy and their caregivers. So this is really circling in both the developmentally disabled and the pediatric groups, and then advocacy groups and some of their members to help us develop these guidelines. This is the current composition of the NAEC board. Sue Herman is at the top left. She is the current president. Fred Latto is the vice president. Miriam Ben-Salem Owen is the secretary treasurer. Kevin Chapman, Dave Clark, Jenny Hopp, Stefan Schul are the current board members. Nathan Fountain is the past president. And then I mentioned I'd circle back to Ellen Riker. She is now the executive director. The NAEC is run out of our Washington, D.C. office. Joanna Gray is her longtime deputy director, and Barbara Small is the programs manager for the NAEC. And they are a tremendous resource, all. If you have questions, if they can't answer your question when you get them on the phone, they will certainly get the answer and get back to you. And if you need help with things or some suggestions or guidance when you're setting up a center or changing your center, please feel free to utilize their services because they really are a terrific resource. And with that, I'll say thank you, and I will open it up to questions.
Well, thank you. And I will be looking for questions in the chat area here for the next few minutes, and we'll see what comes up. While we're waiting for someone else to ask, I was wondering what you think the projected need for level 3 and level 4 epilepsy centers are as far as growth. Is there expected expansion of the number of centers?
So I'm not wise enough to know what the right number is. I can tell you that the current number of epilepsy centers can't realistically accommodate the numbers of people. When you look at epidemiological studies of how many people have epilepsy and how many of them are going to be refractory to medication and need the services of epilepsy centers for management, both medical and surgical, I can tell you that our current volume is not adequate. Now we're up to 260 or so epilepsy centers nationwide that are accredited by the NAEC. There are probably a handful more that are not. But again, the current number doesn't take care of the need.
There is a question asking when you expect to have the committees formed, as far as when that phase would be ready for the committee to start their process.
So we're actually meeting on Monday to start the actual selection. The applications have been, there was an application period. The applications were received, many applications were received to see if people could participate. And now we have to winnow down the number to get a committee. We can't have hundreds of people on a committee, obviously, because it's not tenable, but we're trying to create people both from the diverse groups of individuals that I mentioned, including EEG techs, who I know there are a number of them on the webinar today, as well as epileptologists, both adult and pediatric surgeons, and then the other groups as well, so that everybody will be represented. And there'll be both representation from level 3 and 4 centers, and there'll be representation from various parts of the country, because there are different needs in rural Idaho versus New York City. There are just different needs because of the vastness of states and the number of centers in certain areas. There are different needs. So we want to make sure that those different needs, diverse needs, are all represented on this committee that's going to work on these guidelines.
When would you expect the process to be complete? Is this late 2022 or into 2023?
So our goal is to have the process completed that we'll have the committee seated by next month, so September of this year, start working, and that we can, because it's going to be divided up into sections, it's not going to be that a handful of people have to do all the work. And plus there's a consulting company that's going to be assisting us, so it's not, they'll do a lot of the background work, the literature searches, providing the references and things like that, and then they'll be reviewed and graded and scored to decide on whether they're included. But we expect that the process will be complete by the end of 22, whether it's published by the end of 22 or submitted for publication. That's the goal.
One of the questions
that I've got actually,
I'll let you mute. There's two questions here. One is, do you anticipate continuous real-time monitoring to become a requirement for the epilepsy centers? And then, considering the shortage of registered EEG technologists, how could that be addressed?
So great question, thank you. Yes, we anticipate that real-time monitoring will be a continued requirement for a couple of reasons. And one is a safety issue, that patients are having seizures and they need to be recognized at the time. Nursing staff is going about their business outside the actual rooms where patients in epilepsy monitoring units are being evaluated, so they're not going to be ever present. So you do have to have somebody watching and assessing things. Very good point on the fact that we do not have enough. I'm sorry, I forgot the second part. The second part is pragmatic. You get paid better if you have real-time monitoring by EEG techs than you do if you don't. So that's the hospitals prefer having real-time monitoring going on because the reimbursement is better. So that's that. In regard to registered techs, that's a very real problem. And with no disrespect to CortiCare, you guys are hiring a tremendous number of registered techs, and it's taking away from the pool that we can recruit. So it is an issue. We are getting people to apply for the positions. We're training them internally ourselves, and then hopefully they'll sit for their boards and they'll become registered. And hopefully we can pay them well enough to retain them rather than losing them to traveling organizations or to intraoperative monitoring organizations or organizations like CortiCare, which are all providing tremendous services to facilities like mine. But we do, it is a real issue, and it's not clear to me why we aren't attracting more people into EEG as we have in the past. And it may be the lack of formal training programs. I know when I was at Duke, we had a formal training program. We would have, a handful of students in it every year.
Very good.
Very good.
So we have a few questions that relate directly to the standards themselves. One is asking how many surgical cases are needed to become a level 4 center. Another is whether or not Joint Commission is involved at all with the NAEC guidelines or accreditation.
So let's talk about the second one first, because that's the easy one. No, Joint Commission has nothing to do with the accreditation. Obviously, our accredited epilepsy centers exist in many Joint Commission accredited hospitals, so that the basics for neurophysiology that fall under Joint Commission are already adhered to, as are the surgical standards, et cetera, and nursing standards and patient ratios and all that. But no, our NAEC guidelines are not at all affected by or monitored by the Joint Commission. As far as the number of cases go, I alluded to the fact that the 2001 guidelines prescribed a certain number of surgical cases, and the 2010 ones did not. And the argument was that the previous argument had been that it's a proxy, that the number of cases is a proxy for quality of care. And some of us argued that you can have really high quality of care at centers that do smaller volumes, and by their nature, some centers that are in smaller cities are going to produce fewer cases just because of the nature of the demographics of the area around them. I personally lost that argument in 2001, but won it in 2010. And so the most recent guidelines focus on number of cases that are monitored each year, not number of cases of surgery. Now, the NAEC still collects the surgical numbers from each center, but that's not a criteria by which the accreditation is based. The accreditation is based on the fact that you provide a certain number of monitoring. For the level 3 centers, I believe it's 50 per year, and for the level 4, that's 100 per year. But keep in mind, the types of cases at level 3 and level 4 are different. So to be a level 4, you have to be able to show that you've monitored invasive electrode cases, a certain number of those. I guess many of those will ultimately lead to surgery. So again, there are clearly different criteria for level 3 and level 4, but no specific number of surgical cases that you must do, other than that you've done at least, I think it's 5 intracranial cases per year. That will help designate you as a level 4 center.
Well, it looks like we've covered all of the questions. I want to thank you again, Dr. Lubiner, for sharing this with us. It was a great topic and very timely. We look forward to the work that the committee is going to be doing and the new standards that will come out. And we hope all of you will join us again next month for another webinar from CordaCare. Take care. Good day.
Good day.
Thank you, everybody. Bye-bye.